Hi, my name is Eric Ruderman, and I want to talk to you today about the role of methotrexate in psoriatic arthritis. There's a long history of methotrexate use in psoriatic arthritis. It actually goes back to the 60s and 70s, although most of that information was on parenteral dosing. The first controlled trial of weekly oral methotrexate for psoriatic arthritis was published in 1984. It was a very small trial, 12-week, double-blind, randomized controlled study that looked at placebo versus methotrexate initially at 7.5 milligrams a week and then escalated to 15 milligrams at 6 weeks if necessary. The outcomes included the usual outcomes that we see in our composite measures these days, although there weren't composite measurements used at the time, including tender joints, swollen joints, physician and patient global assessment, etc. The enrollment of the trial was very slow, and in fact they ended up only with 37 patients and terminated the trial early because they couldn't get enrolled. And at the end of the day, the only measurements that came out superior to placebo for methotrexate were physician global assessment and the total skin assessment. Subsequent to that study, there have been a number of open-label observational studies of methotrexate in psoriatic arthritis, all of which have generally suggested that the drug is efficacious, although there haven't been comparators in these studies. One study found actually no difference in either efficacy or radiographic progression in historical controls, while conversely there's another study out there that suggested reduced progression of radiographic change compared to historical controls. In 1997, a meta-analysis was published looking at therapies for psoriatic arthritis, and they found statistical benefit only for sulfasalazine and parenteral methotrexate given intravenously. Lastly, there are other data out there on other non-biologic DMARDs for methotrexate for psoriatic arthritis, including sulfasalazine and leflunomide, both of which showed some modest clinical benefit in controlled trials, though there was no radiographic data in those trials. More recently, we've seen a couple of studies on the use of methotrexate in psoriatic arthritis, which I think is important as we start to look at the use of this drug in this disease. The most recent is a study called the MIPA study, methotrexate in psoriatic arthritis, that was presented at the ACR meeting just this past year in 2010. This was a 6-month, double-blind, randomized controlled study that looked at methotrexate 15 milligrams once weekly orally versus placebo. The primary endpoint was the PSARC, the psoriatic arthritis response criteria. Secondary endpoints included an ACR 20, a DAS 28, global patient and physician, and skin scores. The study enrolled 221 patients, but the dropout rate was quite high, and by the end of the study, over a third of the patients had dropped out, usually for lack of efficacy. They did a completer analysis on the results because of the dropout rate in order to maximize the number of patients they looked at. There was actually no difference at the end of the day in swollen joint count, tender joint count, acute phase reactants, the PSARC, the ACR 20, or the DAS 28, and you can see here on this slide the data for the PSARC, the ACR 20, and the DAS 28, none of which were statistically different than control. And so none of the composite measurements were able to show a benefit at 6 months for methotrexate. Indeed, the only two measurements that showed improvement relative to placebo were the MD global score and the skin scores at 6 months. In the end, what this study fundamentally did was recreate that earlier study published by Wilkins in 1984 that looked at low-dose methotrexate weekly for psoriatic arthritis and found basically the same results, that you couldn't show solid evidence of clinical benefit in terms of composite outcomes, but some benefit in terms of physician assessments and certainly some benefit in terms of skin score.
Eric, does the MIPA trial really suggest that methotrexate is no longer a first-line agent in psoriatic arthritis?
You know, Chris, I think that at first glance it may suggest that, but I think there were a lot of flaws in the study, and in the way the study was done. That was a study that looked at a very specific population of patients. They had very little disease activity. The mean number of swollen and tender joints was just 5. So they may have stacked the deck against themselves in order to show benefit. Certainly they weren't able to show a benefit. I'm not sure I'm able to take that study and say that methotrexate is not effective and shouldn't be used as first line. And you have to remember, after all, that we've only seen the abstract. We haven't seen the publication, so we don't have the full data set.
Eric, based on the quality of the evidence for disease-modifying effect with methotrexate in psoriatic arthritis, what do you think? Is the quality of evidence there, or do we need better data?
I think we simply don't have the data. I don't, unlike what we know in rheumatoid arthritis, unlike what we know in psoriatic arthritis with TNF inhibitors, we really don't have data on disease modification with methotrexate. We don't have radiographic data that's controlled prospective data. All the data that we have really compares what we know with methotrexate to historical controls, and I'm not sure we can make any judgments from it. So I think at the end of the day, what we have for methotrexate and psoriatic arthritis is I think the best we can say is that there's no solid clinical evidence that shows proof of a really effective clinical benefit. And in terms of radiographic benefit, we really have no data at all to work with.